Good morning.
Good morning, sir. Can you hear us?
Yes, I can hear you. Can you hear me?
Yes, that's
All
good.
right.
Good morning.
Good morning.
Hey, Johnny.
Hey, good morning. How are you?
Good.
Good morning, everybody. We have 35 people already logged in and a few people here in the room, and we got a couple of minutes. So we're going to wait a couple of minutes and then just welcome everybody and just give you a little sense of what we're going to discuss this morning. And Chloe, I see that you are on the line, and I don't know if we have your slide about the event that or you can share. You can share
Yes,
your slides.
I can either share my screen. I sent the slide over yesterday to the team as
Why
well.
don't you share your screen right now, and then we're going to be ready to start in about a minute.
Absolutely. I think I can only share if the other participants stop sharing. So let's see.
Yeah.
Okay, perfect.
Yeah, you can share now.
You can share now. We just stopped sharing. So, and then
Awesome.
beautiful. And then give us a minute, and then we'll have you say a few words. All right?
Yeah, absolutely.
All right. Good morning, everybody. We now have, let's see how many people we have. 46 people logged in from all over the place, all over the world, actually. I see a lot of faces, even all the way from Latin America as well as Europe. And we're delighted to have you all here. So we're going to start this morning just very briefly. Chloe, who works in our team, the neuroscience, is just going to tell us a little bit about something for which everybody will be invited as well to participate. And then we will move to a case that Lina is going to present. And I'll tell you a little bit when it comes to that. So why don't I allow Chloe Sermon right now to give us and tell us for a couple of minutes as to what's coming up this next week. Chloe, please.
Yeah, absolutely. Thanks, Dr. Q. So I just wanted to make sure everyone was updated. We are hosting in honor of National Stroke Awareness Month, a virtual Zoom and Facebook Live lecture centered around stroke, and specifically how stroke is relating to COVID-19. And we're just going to have a panel of experts to answer some most commonly asked questions about stroke and COVID-19 and how they relate to one another. So this will be a multidisciplinary panel lecture featuring specialists both in New York as well as from Mayo Clinic across multiple fields, including infectious disease, vascular neurology, vascular neurosurgery, neurosurgical anesthesiology, interventional radiology, and more. So it's going to be a great opportunity for everyone to come together and just learn. It's open to providers, clinical staff, patients, and the community. So we will get you over the invite via email, but we would encourage you all to join. And then if you have any patients or clinical staff that you would like to share that with, or other colleagues, the more the merrier. You can join either via Zoom, or you can also join on Facebook Live. So we're featuring it 2 ways, so there should be space for everyone. And then we'll go over the invite in a minute, but if you have any questions that you want to submit early, you can go ahead and submit those to the email on the screen, and that email is also on the invite for you as well. So the next slide is just going to go over this, the invite. So this is just the panel of experts that we have. We're super excited to have them. Like I said, 2 are going to be joining from New York to give us the perspective of what it's like up there in New York, maybe versus what it's like in Jacksonville and some other areas. So we're really excited. We're looking forward to it, and we would love for everyone to join if your schedule allows. The event is on this coming Wednesday, May the 27th, from 6 to 7 p.m. Eastern Time.
So this is an amazing opportunity. I had the chance of discussing a couple of cases and consults that have come from international patients over the last couple of weeks with multiple strokes, and Dr. Freeman, myself, and I was very, very pleased to see how much knowledge our teams have accumulated, not only in our own experience here, but also in their collaborative efforts that have had with people from all over the world. A lot of those people that you see in New York were graduates from our own program, so we continue to form connections. This is multidisciplinary, all the way from neurosurgery to the emergency room, to infectious disease, neurocritical care, neuroanesthesiology, the issues that come up, the emergency room, vascular neurosurgery. So a lot of different fields coming together for this symposium. So thank you, Chloe.
And oh, yes, of course. Thank you.
And we thank Ravi also for organizing and putting all this together in a panel of experts and partnering with you. So thank you. And everybody's welcome. Send us, come in, join us. Hopefully it'll be a great opportunity for you to learn the experience that these teams have accumulated, and more information to come. So thank you, Chloe.
Yes, of course. Thank you. And I will stop sharing so that you guys can take over.
We'll put the presentation right now. So let's see if we can get Lina's slide right here. All right. So, and then can we put it in presentation form? All right. Let me just tell you a little bit about Lina Marenko, who is working directly with Dr. Chaichana in our laboratories. And she's been leading a lot of the extraordinary work that Dr. Chaichana has been doing in stem cells for metastatic cancer, specifically those that go into the central nervous system. In addition to that work that she's been leading with Kai, for which they have gotten tremendous amount of funding over the last few years. She has been partnered, of course, also with Kayla Alvarado, who's one of our postdocs, and Kai is the leader of that team. And they have a tremendous amount of work coming up in publication for which we're very, very proud of them. Also innovating in biomedical engineering, some devices that they have invented. And we're very blessed to have Lina leading that part of the work. Today, she's going to present the case multidisciplinary. She's going to tell us a little bit more and see what kind of lessons we can learn, and hope to hear from our colleagues from different places from the all over the world. So it's going to be a clival lesion, and we're going to hear more about it. So anybody, to make it a little bit more organized, if you have a comment, if you want to raise your hand, we'll be delighted to have you participate. There's a way when you go to participants in which you can raise your hand, and I'm going to monitor over there with Ricardo and look at the potential questions that are coming up. Lina, take it away. Thanks.
Thank you, Dr. Q, for that introduction. My name is Lina Marenko-Hillenbrand. I am a research fellow, as Dr. Q said, in Dr. Chechana's metastasis lab. Today, I'm going to be presenting a case of a clavicle lesion managed by a multidisciplinary team. So first, I just want to acknowledge everybody that's part of this team, from surgery, Dr. Quinones, Dr. Janis, Dr. Aburiyama, and neuropathology, Dr. Gentoff, and radiology, Dr. Sandu. Before starting, I also want to acknowledge somebody that's very important in my career development. It's my mentor from Colombia. He's an outstanding neurosurgeon and also just an amazing human being that kind of instilled in me the love for neurosurgery that I have today.
José Antonio, gracias por estar aquí con nosotros. Te agradecemos mucho de todo corazón por todo lo que has hecho por Lina también y por nuestro equipo. Thank you for joining us, and hopefully we'll get to see you here in Mayo Clinic in the future.
Thank you so much. Thank you so much, Dr. Llanes. I have been following the clinical sessions and the presentations the last month. It have been amazing to hear very interesting cases, and I'm really, really proud about the future of Lina. She will be one of the best neurosurgeons of Latin American health. Thank you so much. Go ahead, Lina.
Thank you.
Okay. So I'm just starting with the case. This is a 28-year-old female. Initially, she started in October of 2019, presenting neck pain, accompanied with tongue swelling. She went to her PCP. They thought it was attributed to allergies, so they placed her in steroids. The clinical manifestations did not improve. It actually got worse. She continued to swell despite the treatment, causing tongue deviation and dysarthria. They consequently performed an MRI, which revealed a lesion in her clivus, and thus she received a diagnosis for chordoma. The patient then self-referred to Mayo Clinic because she was being treated in another facility just to get a second opinion. Her past medical history, she is on ibuprofen, 200 milligrams PRN, 20 milligrams of prednisone QD. Social history, she is a former smoker. She smoked for 3 years and quit in 2018. Family history, she has an alcoholic father. Systems review, the patient complained of fatigue, difficulty swallowing, and sinus congestion, headaches, and slurred speech. On physical exam, the patient was afebrile and hemodynamically stable. She did have a very high BMI of 36.9, suffered from severe obesity, mental AOA ×3. She had good comprehension. She did manifest again. She did present slurred speech. On neuro exam, she had a rightward deviation of her tongue with right side atrophy. The other cranial nerves were intact. Motor strength was 5 out of 5, symmetric bilaterally in both upper and lower extremities. Sensory intact to light touch. Reflexes normal, negative Babinski, and gait was normal as well. So let's look at her imaging. Dr. Sandu, if you're on the line.
Lina, before we go to that, maybe we can ask one of our residents right here. Just go back to the clinical presentation, see if I can ask Dr. Akinduro, who's one of our senior residents, to make some comments as to what he's thinking when he hears the presentation and the clinical examination before we get into the actual findings on the MRI.
Yeah, thank you. So any situation where you have a clival lesion and you have tongue issues or swallowing dysfunction, I think of lower cranial nerve dysfunction, obviously. So I'm concerned that this tumor could be expanding especially in the caudal and ventral or dorsal direction, to cause either compression of the nerves themselves or extending even far enough to cause compression of the brainstem, which is definitely possible with these lesions.
And go to the physical examination. That was the presentation. Go to the exam.
Yeah.
Look at the cranial nerves, obviously.
Yeah, exactly. So dysfunction, like I mentioned, as far as having the 12th nerve be affected, but slightly surprising that it would affect 12th nerve without affecting some of the other lower cranial nerves. But right now, I'm thinking that this thing extended caudally and dorsally to cause compression of either the nerves themselves or the dorsal root entry zone where they're exiting.
So if you were to think about the lesion, what would be your estimate as far as, we get a little bit more granular? Is it going to be a small lesion, large lesion? What are you thinking about so far?
I think it's going to be large, but like I said, I thought it was slightly strange that it wouldn't be affecting some of the other lower cranial nerves. That's why I think it's extended in more of a caudal direction. But I think it's going to be fairly large for it to be causing this lower cranial nerve dysfunction.
All righty.
Let's proceed to the imaging.
And I think that we have Dr. Sandhu and Dr. Gupta on the line. So if one of them can just take us through this image, that'll be great.
Sure. So go ahead and play that image on your left. What we have is an axial T1 weighted image with contrast. And as we go through the skull base, you can see that there's a large, relatively well enhancing lesion centered in the clivus. But there you see that there's a dorsal extension into the ventral epidural space. There's some mass effect on the medulla and the brainstem. And here you can see too, as it goes down between C1, 2, there's likely involvement of there's obvious involvement of the hypoglossal canal, which would really explain her clinical symptoms. If you want to go to the axial T2 weighted image, these lesions, as you can see here, typically demonstrate hyperintense T2 signal because of the mucoid and fluid contents, and it's pretty characteristic coming from the clivus and its septations. That this is, there's always a differential, but for the most part, this is pretty characteristic for a clival chordoma. So if you can look at the sagittal T2 weighted image, again, we see how extensive this lesion can get with slow growing tumors, and it involves many of the structures around the skull base. And you can see actually, if you go a little bit more, there's, you can see the mass effect on the brainstem. Maybe scroll just a little bit back and you can see this characteristic. We'll get to the brain, yeah, right there. Some people call this the thumbprinting of the, see the pontomedullary junction where the lesions causes mass effect on the brainstem. One of the other things that we have to worry about is we're showing here on the, so we've got a, let's see, this is a contrast enhanced CT. Now this wasn't an angiogram, but if you go back to this, this really helps identify the vascular structures. And you can see that the right vertebral artery is at least partially encased by the lesion, and the left vertebral artery extends to the posterior margin of the mass. So definitely things that would need to be worried about. Also, some of the other vascular structures in the vertebral-basilar junction. Another interesting point to make on these CT scans, usually these lesions are midline. Your differential are also chondrosarcomas, and not to confuse chondrosarcomas with clival chordomas. Sometimes the chondrosarcomas will give you these characteristic rings and arcs of the chondroid matrix, and you'll see a little bit of ossification in this lesion, little specks of calcification. Those are areas of sequestered bone, as this lesion is lytic and aggressive in its sense that it's sequestering pieces of the bone rather than the rings and arcs that you would see in chondrosarcoma. So just a thing to note and be aware of.
Lina, if you grab the cursor and you put it, and you can grab that and go up and down so that I can illustrate what Dr. Sandhu is talking about a little bit better right there.
Yeah, so that's the great sagittal image shows how that lesion has an epicenter in the sphenoid, the clivus, the basisphenoid, basiocciput, synchondrosis. You know, these lesions are tumors of notochordal remnants, and you can see where it's centered there and then expands both ventrally and dorsally.
And Johnny, can you comment right there on the skull base as well as C1 and C2? Probably that CT scan is a good one.
Yeah, you definitely can see that there is a erosion of and replacement of the bony structures. So C1 and C2 are near completely replaced by tumor.
Go a little bit more medial on that, Lina, so you can illustrate that.
You see how that extends along the occipital condyle there. You see the occipital atlantal joint on that side. And if you go a little more anteriorly, you can see how the bone is eroded.
So the clivus is almost gone in some of the images, Johnny. And then you see part of the arch of C1 and the tip of C2. And looking at that, can you comment as to how much of that it's involved?
Yeah, I mean, the majority of it looks like the entire anterior arch of C1 is replaced. And then if you look at the occipital condyles are involved, and then the tip of the odontoid there. But see, that's a great image right there. To go back one more, you can see the anterior arch of C1 where there's a little even posterior convex replacement of the bone there.
And that, of course, in the axial image, you can actually get a good sense of the damage to all those bony structures as well. Yes, I think it becomes important as to what we're going to do surgically and how we're going to go ahead and take care of this patient. Anything else, Johnny or Vivek, that you want to add as far as the radiographic finding? I think that your differential diagnosis, you're leading more towards a chordoma than a chondro type of lesion. And Vivek, anything from your side?
Yeah, I think I'll just make a comment. I think the involvement of the clivus, of course, is leading to direct extension into the occipital condyles, because this is just one continuous bone. And as the tumor is going into the prevertebral space or the preclival space, is extending inferiorly and then secondarily invading the craniovertebral junction, in the sense that it is invading the anterior arch of atlas from the front and the tip of the odontoid from above. So it is basically the soft tissue extension which secondarily extending into these structures of C1 and C2. And I think I don't really have much to comment because it's been sort of very elegantly described by Dr. Sandhu. It definitely extends more towards the right side. As I said, that it definitely is taking the hypoglossal canal on that side, and the major ligamentous structures are at risk because of the anterior bud ligaments and the alar ligaments, because the erosion of the sort of the occipital condyles and the tip of the odontoid. So you have to assume that the alar ligaments, which are very critical for the stability, are involved. And I don't know how much of a surgical implications they have, but that definitely put the craniovertebral junction at risk of instability.
Thank you, Vivek, and thank you, Dr. Sandhu. Johnny, thank you.
Due to the patient's symptoms being the hypoglossal nerve palsy, her difficulty swallowing due to the tumor displacing the nasopharynx forward and obstructing it, the midline location, and because most of the bulk of the tumor was above C2, above the nasopalatine line, the goal was an extended endonasal approach with maximum safe resection. They also considered doing this surgery in 3 steps. The second step was also considered to be transcervical using microtubular retractor. But later on, it was decided to best do it transnasal.
And I see Dr. Janus, we're going to be, Jeff, Dr. Janus is the chair of ENT. We're going to be ready to hear your comments. If you can comment so far as to what were you thinking at this point as far as the approach is concerned, Jeff?
Sure. Yeah. Obviously, the size of the tumor and its location kind of made us, I think, initially want to entertain doing at least a singular endonasal approach followed by either a transcervical or a transoral approach. And a lot of that's going to depend on tumor consistency when you get in there, and how much of it will decompress, like how much of the tumor is suckable essentially while you're doing your endonasal approach. The sort of fortuitous aspects of the tumor were, given the fact that it didn't really encase the internal carotid arteries, at least not on the, I think it was the left side where it extended out a bit more, but rather pushed it out laterally, which is, was more fortuitous for being able to do an endonasal approach. And I think that our initial thought was to go in and see how much of the tumor we could decompress endonasally and have a contingency plan for a transcervical approach if needed.
And Jeff, when the patient came to us, they had proposed a different surgical approach. Can you comment as to what another team had proposed for this case?
Yeah, so some of these larger clival chordomas really, for visualization purposes, if the team isn't necessarily as comfortable with doing an extended endonasal approach or a transoral approach, they'll consent the patient for a lip split mandibulotomy, mandibular swing. Obviously, what that is, it's creating an osteotomy in the parasymphyseal region of the jaw, and then swinging the entire jaw out laterally to expose the posterior aspect of the pharynx, and giving you the ability to have a better angle on the nasopharynx and posterior pharynx, so you can see what you're resecting and use larger instruments. That being said, a lip split mandibulotomy is very morbid to a patient, insofar as you have to split the jaw, swing the jaw, make an incision along the floor of the oral cavity, and extend that all the way back to the pharynx, essentially. So obviously, this is a young lady. The prospect of having her jaw split and having incisions on her neck and face were relatively horrifying to her. So I was glad that we were able to offer her a different approach.
Anybody from our colleagues from Colombia, Peru, Mexico that want to comment as to the way that we're thinking at this point is through an endonasal first stage, potentially transcervical as a second stage, and then a third stage obviously is to stabilize the spine. But any thoughts before we go into the surgical approach that Dr. Janus was able to get us through and for the tumor resection?
This is Gabriel Vargas from Bucaramanga.
Gracias, Gabriel.
I think that these kind of lesions, very big lesions, are difficult to take into one surgery. But of course, one of the most used approaches that we have right now is that endonasal extended approach that we can really reach the C2 area up onto the clivus. So I think this is the best approach to go and try to work with this lesion. And it's amazing how this big lesion is not causing not too much to the patient, and that only that 12 symptom, but no more than that. So always is difficult to take the whole lesion, and even we know that surgery is the most important treatment for this kind of patient, because the radiotherapy and other kind of treatments are not good enough in order to take this. So we'll see what you did with this approach with ENT and neurosurgery team.
Thank you, Gabriel. We're going to talk a little bit more about radiation as an adjunct as well. But I see another hand right here.
Yeah, we have Dr. Jose Name, who's Lina's mentor from Colombia, right here raising his hand. Dr. Name, hello.
Thank you. Just a short opinion about the case. It's a really challenging. I think it's a really big tumor, and to remove the whole mass will be almost impossible. It takes also the vertebral artery on the right side, and it's extended for endoscopy in the nasal extended approach. I think the most of the tumor is over the nasopalatine line, so we can choose that approach. But nevertheless, it's not going to be possible to remove all the tumor. I think the goal of the surgery in these cases could not be to cure the patient, to relieve the symptoms, to relieve the swallow problem that she has, and to reduce the growth of the tumor on the time. I think that will be the goal of the tumor. Really challenging. Thank you.
Thank you, Jose. That's a very, very good point. And this is why, of course, when Dr. Janes saw the patient with us, he felt that even doing a splitting the mandible and stuff, still some of us who have worked with that kind of approach is not an ideal approach. The corridor is still narrow when you're getting down there that deep, and you're still not going to cure the patient from surgical resection. But we used them for many years, and luckily we have some other possibilities. So let's see what we ended up doing right here in the first stage, and we're going to have Dr. Janus comment as we're going through this.
As I was saying before, this case was divided into 3 surgeries, 3 phases. The phase 1 and phase 2 would be both extended endoscopic endonasal approaches to the clivus, and phase 3 would be an occipital cervical fusion. So here we have the first phase of the surgery, phase 1. Let's play the video. The patient was positioned supine with the head fixed in the 3-point Mayfield head holder. Here you can see the infiltration of the middle and inferior turbinate, the lateralization of the turbinates. Same goes for the other side. If we can have Dr. Janus comment.
Yeah, sure. So it's fairly common, when you get back to the nasopharynx, depending on the age of the patient and their previous surgical history, for them to have some redundant nasopharyngeal tissue. I think we'll see here right after this the lateralization of the turbinates, which helps us for our access. Really, it just kind of gets the bone and the soft tissue out of the way, so we don't tear them up while we're doing the surgery. We then sort of tamp down the nasopharyngeal tissue and cauterize that all the way down to kind of get it out of the way and facilitate access. We then can sort of see some of the tissue just anterior to the clivus, where we were able to split the muscle using needlepoint cautery and sort of move that muscle out of the way as well. And then we have a nice corridor to the clivus to be able to decompress some of the tumor using ringed curettes. In this part, obviously Dr. Quinones was critical in removing the tumor as we got closer and closer to the brainstem.
And I think that one important aspect of this, Dr. Janis, is how we kept going back and forth, doing like right there, you open it more and more as we're debulking tumor, you're making the window larger, as you can see right there. And just tell us what instruments we're using, because some of the side cutters were not strong enough.
Yeah, and so, I think that you can kind of see that we're using a combination of both the Nico, which is a sort of a smaller shaving instrument, versus the micro debrider, which honestly is a larger version of the same thing. That I think kind of helped us out with some of the more tenacious material, trying to be able to sharply cut that. Again, as long as we stayed a bit anterior, I think we were relatively safe moving out laterally because the tumor itself had lateralized the carotid artery. Although obviously we have to worry about whatever residual hypoglossal nerve tissues out laterally as well. As we loosened up more and more of the tumor, however, we could kind of mobilize it using some of these ringed curettes that are more common in the neurosurgical practice. So.
That's the Nico right there as we're getting close, and the more sackable portion we were using the Nico. We got a little bit of CSF at one point and we're bipolaring, and we go back and forth between that side cutter that Jeff beautifully uses. And I was reluctant to use it because it's definitely more powerful, but in some areas the Nico wasn't even touching. You can see the big space that we have right there. And at this point, we brought the ultrasound, and we didn't feature this, but we felt that we were dangerously close to the actual carotids laterally. We weren't quite sure how far off and how far away we were. And in this particular case, we did not use the intraoperative MRI in the first phase. And Dr. Janis and I talked about this, and potentially that could have helped us, because even the Doppler was telling us that we can hear some sounds, and we could be potentially close to the vessels, the arterial vessels laterally. So at that point, we looked at each other after working for several hours in there and says, I think that for today, this is as much as we're going to be able to safely do.
And then you can see at the end of the case, we wound up using a right-sided nasoseptal flap to cover the defect we made, because we did have some CSF and exposed bone and that sort of thing that you don't really want to leave hanging out in the nasopharynx. And so, yeah, you can see, using that is a version of, I've got a different one now, but there's a version of a Toriumi suction periosteal elevator, which is a really nice tool for being able to get underneath the perichondrium for the nasal septum. That Toriumi elevator is commonly used for septoplasty, and is named after a plastic surgeon, but I really like using it to raise our nasoseptal flap, and then we mobilize it, put it over the defect, frame it with Surgicel, spray it with Duracell, and bolster it with nasal pore.
And we couldn't see it in the video very well, Jeff, but we did have a little bit of CSF. We got into a smaller space of CSF as we were going towards the right side inferiorly. And of course, we wanted to make sure that we protected that as much as we could at this phase.
Absolutely.
All right, Elena, let's see what we got next. Let's see what we got in this scan.
This is the post-op MRI.
And Johnny or Vivek, if you guys want to comment on this, that'll be great. And then I'm going to ask some of our colleagues from around the world in regards to the surgery. If you want to comment, please raise your hand, and that way we can monitor right here and give you an opportunity to comment on the surgical approach and the nuances and things that you could have been doing differently yourself.
Yeah, so what we're showing here on your left is an axial post-contrast T1 weighted image post-surgery, you can see the corridor that was used and the major debulking of the tumor centrally. You got a really large resection. We can also see that they're sparing. You can hold it right there. Go back one, and you can see the internal carotid arteries there as they go into their petrous canal. They're lateral and preserved. We can go to the T2. Again, the T2 weighted images will also give you an idea of how much of that tumor has been resected, and really, really nice post-surgical outcome.
It was a good outcome, but we still had a lot of tumor left. As I was looking at it with Jeff, we realized that that right side that we thought that we were closer, it turns out that we had about 1.5 centimeters of tumor.
Yes.
Go ahead, Dr. Gupta.
Yeah, I mean, I was also looking at that. It seems that a lot of your tumor removal is actually midline and slightly to the left. So it's actually, I'm kind of curious as to why you, if you just go back on those sort of axials towards the internal carotid in the upper neck, you can see that the carotid is still quite lateral, and with it, there is a substantial chunk of the tumor sort of from the lateral margin of your surgical bed on the right side to the carotid artery. But I mean, I can understand that you have such a limited corridor coming from where you're doing. And actually, I mean, it is a very good resection. The other thing to keep in mind that these tumors have an affinity to invade the dura and sometimes can extend intradural. So the encountering of CSF during surgery as you're removing it is not uncommon.
A very good point. I have a question from Dr. Vargas right here that we can ask him to comment as well. But what we did, Vivek, this is when we were inside in the operating room, both Jeff and I, we didn't get a good sense as to where we were in the right-hand side, that's ipsilateral side, and we thought that we were farther than we were, and we brought the Doppler to see, and we can hear arterial sound, so we assumed at that point that we were a little close to some important arterial vessels. We did not have the intraoperative MRI. Go ahead, Jeff.
No, I think that's a great point. I mean, I think the biggest challenge you face with some of these larger tumors, and I know this isn't really news to a lot of the folks on the line, but when you have a larger tumor like this, as soon as you start to decompress that tumor and things are falling towards you, and you're using powered instrumentation to debulk the tumor, your image guidance becomes quickly no longer valid. The carotid artery and the musculature in that area and everything sort of starts to fall into your field. And I think what happened to us towards the end of the case was, we got out the Doppler, could actually hear some pulsations, and we were a bit worried that, you can't tell the volume of tumor that you're taking out necessarily with a lot of that powered instrumentation as well. And we were worried that we had decompress the tumor enough to have the carotid artery start to fall towards us, and we obviously don't want to get into the carotid artery with powered instrumentation. And I feel like exactly the point that you pointed out, that there was quite a bit of tumor left out there laterally, prompted our decision for intraoperative MRI during the second phase of the case.
And Dr. Vargas from Colombia has a question. And Ravi, I see you on the line right here. He's asking whether or not there's a role for embolization or having the potentially hybrid room, doing this case in a hybrid room. Ravi, would you mind commenting on that? Dr. Talk is our neurovascular. Go ahead, Ravi.
So, doing vascular and tumor, I think there's definitely a big role for embolization. I think as our specialty, I think we're still kind of sectored into those classes. And if you ask me, I've done chordoma surgery and I've done embolization. I still don't know, because I don't think we do enough angiograms on those patients to see what their vascularity is. And so chordomas in general, it's not a hypervascular lesion. So the issues with chordomas are not bleeding. So I'm not sure there is a role for it. I see a big role for embolization for hypervascular tumors, definitely hemangioblastoma, hemangiopericytoma, and some of those meningiomas that have high vascularity. Those I don't, like, for me doing both, I don't want to take any patient to the OR without embolization because I know how much difference it will make. For chordomas, I think it's not required because it seems to me like our issues are not. Our issues are how to get access, how to protect the carotid and so forth. And I think a hybrid room would be ideal because if you look at this lesion, you know, nowadays you want to leave the OR with some certainty. I did last night a fistula that has 5 surgeries before, and if I have a hybrid room right in the OR, I can do an angiogram and know before I leave the angiogram that the room that I have done it. So that's the value of hybrid rooms. So I hope to see it soon with us, and it will be a great addition for, especially for centers who are considered the ultimate referral center. You don't want, you want to be done when you finish the surgery. So.
Wonderful. Thank you, Rev. I see Victor Garcia Navarro from Guadalajara, Mexico. Go ahead, Victor, please.
Hi, Alfredo. I think that this is at all not an easy case. And as Jorge, if I remember well, he told before this CASAM line or nasopalatine line make us think that we will need a second surgery, and this could be the transferal that you already said before. I'm not sure if Dr. Janus had an article or wrote an article about the Janus flap, that even if you have a leak in the second surgery, you may have this bilateral septal flap, because we know that we will have a really big defect there, and even it's easy to get lost during the surgery. And we know for sure that we will have a third operation, but it's really important that the patient knows before the first surgery that he will need radiotherapy or radiosurgery, and a second and maybe even a third surgery. But this is the best opportunity that he will have. More is better always in these cases. That's my opinion.
Wonderful. Thank you. And that's exactly what we did. And Jeff, will you comment about this issue of the defect and the flaps and how you were thinking about this? Because you had a thinking process around this process.
Yeah, so I can't take credit for the Janus flap, unfortunately. I think that's named after the Roman god. But from the standpoint of this particular case, the way that we harvest our nasoseptal flaps always is in a way that even for expanded intranasal approaches, we kind of do our best to spare the contralateral septal branch of the sphenopalatine artery to be able to perform a secondary flap. And indeed, in this lady's case, our first flap, you'll see when we show the next video, healed in fantastically well. It could not be peeled off of her previous surgical defect, and so we had to use one from the contralateral side, that being her left side. Always having sort of a contingency plan. I mean, we didn't take out the turbinates for this, or the inferior turbinates for this case. We didn't take out any of the lateral nasal mucosa. And so we continue to have options as far as correction of CSF leak and coverage from an endonasal standpoint in the event that we need them. So we have options. We spared the contralateral nasoseptal flap, and actually, even though we tried to salvage her first right-sided nasoseptal flap, we could not, and therefore had to use the left, which was fine. I saw her a few weeks ago, and it's healed in just as well as the first one. So,
thank you, Jeff. And of course, we're thinking about the future because she's definitely going to need radiation therapy, and we'll touch upon that in the next few minutes. There was a question here from Pamela Garcia about the role of neuronavigation. I think Dr. Janus already commented on that. Is for us, it's very useful to have a guide. It's not, at the end of the day, doesn't replace our understanding of anatomy and different regions. But as Dr. Janus said, you get to the point where things begin to collapse towards you, and those systems can be a half of a centimeter, sometimes all the way up to a centimeter off, and you have to be very careful. The deeper you get, the higher the risk of you being off. And that's when we brought the ultrasound, and this is where we start thinking this could have been a good case to do in our intraoperative MRIs, which we have. available. But we also knew from, as Dr. Garcia mentioned, that most likely this was going to require several stages of surgery. And that's why Dr. Janus was also preserving a lot of the nasal anatomy to be able to go back. All right, let's keep going so that way we go to the next videos and we finish by 8 a.m. Eastern time.
Post-operative course, the patient was transported to the ICU for overnight management. She was extubated the following day and discharged home on post-operative day 2 with taper steroids and follow-up with ENT and neurosurgery. She noticed an improvement in her voice, no post-operative complications. Before, just to clarify this, before she was operated, she was tested for COVID-19. Which is important due to the current situation in transnasal approach.
Maybe Jeff, you can comment on that, because that's obviously has been reported, especially for endonasal, type of work with patients that COVID-19, as to why. Of course, this was in the middle of the pandemic when we did this case because she was getting worse. But can you comment about the risk of this situation?
Yeah, I don't know how many people on the line have been tested for COVID-19 via a nasopharyngeal swab, but it certainly feels like a brain biopsy. In this patient's particular case, you worry that after you've done one surgery on there and sort of in there and opened up that corridor, that they might actually damage something by performing a blind nasopharyngeal swab into your operative field, in which case it could actually be more like a brain biopsy. And so, here at Mayo and I'm sure elsewhere, we have a protocol for patients who are coming back post-operatively after skull-base surgery to undergo oropharyngeal swabs in order to rule out COVID-19 for both their in-clinic post-operative nasal debridements and for any additional surgeries that they might have. We have a protocol to use an oropharyngeal swab that we indicate to the testing service here.
Pathology, Dr. Gentoff.
Thank you, Mark. Dr. Gentoff, Director, Neuropathology Core.
So if you look at this case, you can see that the tumor cells are growing out in cords. They have sort of an epithelioid type look. And you see this matrix in the background. It looks a lot like cartilage. And some of these tumors can actually really mimic a chondrosarcoma. If you look here, you can see that the tumor has very vacuolated cells, like in this tumor cell right here. Those are called phyzoliferous cells, and they're sort of the buzzword for a chordoma. Chordomas have an interesting staining pattern in that they are both S100 and keratin positive, and they also stain positive for brachyury. So this is a very unique staining pattern that only chordomas have. So this is called a classic type chordoma. As I said, there are two types of chordomas, classic type and a chondroid chordoma. It was thought that chondroid chordomas had a worse prognosis, but it's since been shown that the prognosis is pretty much the same between the two.
Thank you, Dr. Gentoff. We really appreciate it.
This is
Let's
just
see if we can keep us for the next two videos so that we'll finish in 12 minutes.
All right. So the preoperative MRI, there weren't any substantial changes. We go to phase 2, again, an extended endoscopic endonasal approach. This was performed with neuronavigation as well as intraoperative MRI, as Dr. Q mentioned. And this is the video. Again, the patient was position supine.
Maybe we can have Jeff comment right here as you let the video play so that we can tell us what happened the second time around, Jeff.
Yeah, so our first nasoseptal flap healed pretty well. I spent a little bit of the beginning of this case trying to mobilize the nasoseptal flap, but ultimately just wound up completely taking it out because, as you can see, it was fairly stuck, which is what we wanted, so that's good. We then wound up using a combination of cold knife and microdebrider instruments, both of which you saw in series there, removing our previous fat graft that we put in and also healed in and fibrosed nicely. We then began to try and encounter some of that laterally positioned tumor that everyone's mentioned. And I think the problem that we ran into in the first case that we were able to rectify to an extent with the second case is that a lot of that tumor was a little bit more fibrous out laterally and actually required removal with powered instrumentation, and wasn't just suckable and didn't just collapse into the field as easily as some of the more centrally located tumor. So using a combination of ring curettes and microdebrider, which you see both in series there, we were able to debulk a lot of this more fibrous lateral tumor and felt a lot more confident about that. And then at some point in time, I don't know if we're going to show it, we did pause, we got an intraoperative MRI, and to combat that sort of conundrum that I mentioned earlier of having things change in the operative field for some of the larger tumors, we actually loaded our intraoperative MRI into our stealth machine and were able to use the new position of some of the normal anatomic structures and adequately isolate any residual tumor and help remove that. So it was nice to be able to get that intraoperative MRI and actually use it in tandem with image guidance real time.
And the second time we didn't even bother with the NICO, which is very nice for soft tumors, but for this tumor wasn't even touching it. So we just got Jeff's side cutter. You can see right there, we're going back and forth all the way. I think we appreciated the dura at one point. And as Dr. Janet said, we got the intraoperative MRI. We're using the navigation that we reloaded there, and we're trying to understand exactly what that's bone right there at the base. We're cleaning, going all the way around. And here we got
closure.
Yeah, the closure. That's the hole that we made right against that corner in the dura, Jeff, where we got the Vigor CSF.
Yeah, and then closure very similar to the first one. This one we did have more of a CSF leak, which is a phenomenon, as mentioned earlier, to be expected given the nature of these tumors. We were able to pack that area with fat. There's our left-sided nasoseptal flap, which you can see was harvested in a very similar fashion using the Toriumi suction elevator, and then positioning this over our defect, and kind of using both of using the binaural approach here to try and see where we're positioning that. Then we framed that with Surgicel again, sprayed it with Durasteel and bolstered it with nasal pore. The nasal pore was removed within 2 weeks of the operation because that has a propensity to get super infected and begin to become foul smelling to both the patient and their partner. So I take it out in I suction it out even though it's biodegradable in about 2 weeks to keep it from becoming an infectious nidus over the flap. At that point in time, I could inspect her flap. It was well healed, well positioned, and had no evidence of CSF leak.
Okay. So now let's see what we got this time around in the scans. Now, Vivek or Johnny, if you can comment on this.
Sure. So we have axial T2 weighted image that we're going through right here, and you can see that the approach from the second stage has significantly debulked more of that right-sided aspect of the tumor. And then see, we go there. Again, you can see that the vertebral artery flow voids are preserved, the internal carotid artery flow voids are preserved. So got a much larger debulking on this stage.
And of course, Johnny, because I see Dan Trifiletti also and Dr. Spector also from the Dominican Republic, I'm going to ask them to comment on radiation. What we were trying to do is give a space between the tumor and the brain stem. If you can comment on that, I'll appreciate it.
Sure. So, I mean, if you go back and look at the axial T2s and on the pre-op scans, you notice that the posterior margin of the tumor extended all the way to the ventral aspect of the vertebral arteries. Now, as you go through there, you see that clearly that there's a CSF space there, as well as if you go up just a little bit higher, you can see the ventral aspect of the medulla and pons. The tumor in the previous were indenting, giving that same thumbprinting appearance, whereas now you've relieved a lot of that impression on the brainstem.
So a much better resection. in this time around, but we're not done yet. So let's see if we can go to the next phase.
Post-op, of course, the patient did well. She did present increased temperature, but they did a lumbar puncture. CSF gram stain ×2 was negative, as well as culture. It resolved on post-operative day 1, and she was treated prophylactically with antibiotics with no other complications. Again, it's the same classic chordoma that Dr. Gentoff mentioned. And now we're going to phase 3, occipital-cervical fusion, performed by Dr. Aboriyama.
And Kingsley, I don't know if you're on the line or not. He's actually in the operating room, but we're gonna go through this procedure that Dr. Aboriyama performed. Let's see if we can just play the video. So he's performing the occipital cervical fusion. Right now you can see they're looking at the patient from the back, of course, the occipital area. He's beginning to fuse, you know, from top to bottom. You can see the camera going from different angles. And then we are about, he's putting at this point the screws that appear to be C1 right there.
You got this thing that's still like locking.
And it should be, I see C1 clearly. Maybe hiding under that is going to be C2. I think I see him. That's C1, his fingers in C1, and beyond that is going to have to be C2 right there. Now you can see C1 and C2. I don't know if we are going to see at this point. This is the harvest in the iliac crest. Is that? Oh, the rib. In the rib in place, and now they're putting IV with their fusion bone graft to make sure that everything is going to fuse. Now they're putting a drain. Okay. He did the surgery pretty quickly in a couple of hours, moved expeditiously. You see a small incision for such a big surgery.
These are the post-operative cervical radiographs that show stabilization of the cervical spine.
So he went C2 and C3. So that was C2 actually. So C2, C3. So you can see the occiput to C2 and C3.
The patient was discharged home on post-operative day 4. She's doing well with improvement of her dysphagia, and she is undergoing occupational therapy for the speech, for the slurred speech.
So I see Dr. Trifiletti here, radiation oncology. What are we going to do then as far as therapy for this?
So she needs radiotherapy given the tumor diagnosis and subtotal tumor resection. And I think the interesting thing about chordoma, from my perspective, is the advancements in radiotherapy technique over the past 50 years. So you should know that we treat a lot of nasopharyngeal cancers, carcinomas, and oropharyngeal carcinomas with radiotherapy. That's much more common than chordoma, but in the same anatomic region. And the old way to treat this would be with opposed lateral x-rays. Like if you imagine a lateral x-ray film, should cover the whole clivus and C1, C2. So it would be a huge field. The parotid glands, the medial temporal lobes, the pituitary, the pharynx, all of that would get radiated. And that is super toxic. So we figured out ways to get the radiation there with less morbidity through these advanced radiation techniques, and also at that same time showed that dose escalation improved tumor control and survival in chordoma. So the dose we try to go to in chordoma is as high as we can, and we would typically prescribe something like 70 or 78 gray, pretty high doses for chordoma, and the brainstem tolerance is 54 gray. So we're like 30% over the tolerance for the brainstem, and these people can get a lot of bad side effects from this. So it put more pressure to improve radiotherapy delivery. And that's where proton beam radiation has really been shown to be effective. So proton beam radiation allows for less irradiation of normal tissue. And in a circumstance like chordoma, it's particularly effective because you can get a higher dose of radiation to the tumor and less radiation to the immediately adjacent structures. So that's kind of like the current state of the art. The next state of the art is adding systemic therapies with radiotherapy to this. So we have a clinical trial evaluating a brachyury vaccine given concurrently with radiotherapy to try to improve clinical outcomes. And then the next phase is heavy particle therapy as an alternative mode to get more radiation to the tumor and less to normal tissue. So we're constructing a carbon ion therapy center here, and chordomas are really like the prototypic ideal example of a great patient to be treated with that technology, because it has alternative modes of cell kill, so that makes it more destructive against the cancer. So you can get more radiation dose in there. It's more effective against chordoma, which is considered radiation resistant. And also it has less irradiation, even more than proton beam radiation. So for many patients with chordoma or advanced nasopharyngeal cancers with intracranial extension, et cetera, really benefit from that therapy. So that's kind of where we've been and where we're going. It's an exciting area to be in for sure.
Wonderful. Thank you, Dan. So basically, Dan is already treated with protons. He has got already clinical trial with a vaccine, brachyury, so enhance the therapy. And he's already working. I think in a couple of years, Dan, we're opening the heavy particle, the carbon therapy center here. The first one in America, if I remember correctly, one of the few in the world. So congratulations. Looking forward to seeing the results of these future clinical trials. And I know you have also already an NIH grant looking at some of these things. So wonderful. Thank you. So any question? Did someone raise their hand, or was there any other potential pearls from our audience around the world? Anything else that you would have done potentially different that you should consider? Arturo, go ahead.
Oh, yeah. These kind of lesions in every part of the world are a challenge. The volume of the tumor are very huge sometimes. And when we make the plan to operate these lesions, we have maybe 1 or 2 or 3 steps. In my hospital, we have experience with these chordomas, with these huge chordomas. And maybe in the first time, we can reach all the lesion in 1 step by transoral approach. Obviously, this approach is with more morbidity, and we have to make a tracheostomy. But sometimes we can reach all the lesion by this route. Navigation is a very, very good technology to try to avoid make some injury in the internal carotid artery. And sometimes we need to drill all some clivus bone there, and this kind of lesion have sometimes a high recurrence. Then the chordoma have high recurrence, and the long term of these lesions have maybe 5 years of long-term survival. Then this kind of lesion have in the most of the patients have not very well improved outcome. But in my hospital, we have some cases or with the Mayo balloon cases, but we have with ENT and the head and neck surgeons, we have to make a big plan.
And Arturo, just to clarify, of course, you're talking about Mexico City, and what is your access to either photons or protons for your patients?
Unfortunately, we don't have enough proton beams in Latin America. I mean, maybe in all Mexico we have only one proton beam. I'm not sure of that, but usually we have the other kind of radiations. But usually we need to looking for a proton beam radiotherapy.
Because if you look at the data in the United States, and Dan is very, Dr. Triflet is very familiar with this, and that's what he advocates, and he talks about how the proton beam therapy is really become, at least in the United States, the gold standard for the therapy for this type of tumors to have a much better long-term control. You know, you escalate the dose. So, Ricardo, you had a question.
Yes, Dr. Trifiletti, this is Ricardo. I want to know what's the role of preoperative proton beam therapy for chordomas. I've seen some cases that they give preoperative proton beam, so I want to know.
Good question. Unknown is the answer. Probably shouldn't do it, but I think people do it for sure. So these cases are tricky because obviously they can occur anywhere on the spine, and every patient is so different. It's very hard to compare. Typically, they have multiple surgeries, so there's sort of a question of, do you do it before anything or in the middle of it? It's certainly easier from a radiation oncology perspective because by the time you guys do 4 surgeries and put a bunch of metal all around it, I can't tell what's going on. You know, where's the tumor, what's post-op changes, what's what. And that makes it very difficult. It's much easier for me if I can treat a tumor than a post-operative bed. But at the same time, there are major barriers, major problems with preoperative radiotherapy that are magnified in patients with chordoma as compared to brain metastases, let's say. So one example is you don't have a diagnosis if we treat truly preoperatively. If it's a chondrosarcoma or a metastasis or whatever, that would have a big implication on my radiation planning, etc. And I would love to know that before I give the radiation. The second significant risk in preoperative radiation or radiosurgery for chordoma is a wound healing issue. So the mucosa is covering and typically displaced by the tumor in the majority of these cases, and you're manipulating it as part of your surgical entry. So a non-healing ulcer in the nasopharynx or oropharynx or non-healing surgical wound as a result of delayed healing from radiation is a known risk in patients with sarcoma and certainly a risk in this. In brain metastases, it's less of an issue because the skin's not really getting a lot of radiation. So, I mean, I'm not against, trying new stuff and good ideas, but I think that there's other areas that preoperative radiation can be validated first. And then if there's strong signals and rationale there to move it to chordoma.
Thank you, Dan. So more information to come in the future. So, well, let's wrap it up. We have a summary right here. Lina, what do we have? Who joined us from what parts of the world?
Yes, sir. So we have a total of 14 countries that join us around the world. From Chile, we have 1, Colombia 28, Dominican Republic 3, Ecuador 13, Salvador 1, Honduras 1, Italy 2, Mexico 13, Panama 6, Peru 13, Portugal 5, Spain, Switzerland, and United States of America.
Wow, amazing. So, and we encourage you guys to join us, keep joining us. And of course, we love to hear from you, ask questions, present your cases. And we thank you all for joining us today in this amazing day. And have an extraordinary weekend. In the United States, it's a holiday weekend. It's Memorial Day weekend. So enjoy your weekend. And thank you for all you do to take care of our patients during these challenging times. Thank you.